Today I am going to present case on a swelling history. A 55-year-old woman who is a teacher from Tirunelveli came with the complaints of swelling over the left side below and in front of the earlobe for 5 months, which is insidious in onset, progressive in nature, painless, not associated with fever, and attained the present size. Local examination. After getting consent, the patient was examined in a well-lit room. Inspection on a left parotid region. Single swelling of size 4 into 3 cm located on the left parotid region, inferior and anterior to the ear lobule. The swelling rises the ear lobule. Shape is irregular, lobulated surface. Skin over the swelling is normal with a well-defined border. Extend vertically 1 cm inferior to zygomatic arch and 1 cm superior to angle of mandible. Horizontally 2 cm anterior to mastoid process and 5 cm posterior to angle of mouth. The retromandibular groove is obliterated. No dilated veins, scars, sinus and fistula over the gland. Right parotid region is normal. On inspection of the oral cavity, mouth opening is normal, good oral hygiene. Parotid duct opening is normal with no purulent discharge. No bulge of the left tonsillar fossa. Opposite tonsil is also normal. Lips, gums, palates are normal. Palpation, not warm, non-tender. Inspectory findings are confirmed. On the left parotid region, a single swelling of 4 x 3 cm size which has a lobulated surface, well-defined margins, firm in consistency. The skin over the swelling is pinchable, which is mobile and not fixed to the underlying masseter muscle. On bimanual examination, the swelling is deep. The deep lobe is not palpable, which means it's normal. On bidigital examination, parotid duct is normal. The right parotid region is normal. Facial nerve examination. There is no signs of facial nerve palsy. And lymph node examination. No enlarged or palpable lymph nodes over parotid and neck regions. Diagnosis. A benign tumor of superficial lobe of left parotid gland. Probably a case of pleomorphic adenoma.
Can you please go back to your history part? Is this all the history or any personal history, family history?
Short case.
Nothing.
Short cases. Okay.
Yeah. But is there any relevance for this swelling in parotid and his personal history? What are the things you look for in personal history?
Any cigarette smoking or...
Yeah.
Yes.
What swelling is related to cigarette smoking?
Warthin's tumor.
Yeah, good. So this is a painless swelling for 5 months.
Yes, sir.
Duration.
Yes.
Okay. Was it progressively increasing in size or is there any history of rapid increase in size?
Progressively increase in size.
You have said pain and fever. Why should you, suppose somebody has got parotid enlargement with pain, what are the possibilities?
It can be parotid abscess.
Okay.
Or parotiditis.
Parotitis. Okay. 5 months duration, a swelling with pain. What is the possibility?
Maybe parotid abscess, parotitis.
Think beyond inflammation. To produce pain, you should have nerve involvement.
Adenoid cystic carcinoma.
You should have pain.
Yes,
you should have nerve involvement.
Yes, sir.
In which...
Adenoid cystic carcinoma.
So don't have to be specific.
Okay.
See, doesn't mean adenoid cystic alone involves nerves. Mucoepidermoid also has got perineural spread. But you malignancy. You should say malignancy when there is pain. That's why you say, so 5 months is not a very long duration. It's relatively short duration in a female. And why is it fever?
Maybe an inflammatory pathology.
You suspect inflammation to be there for 5 months in parotid?
No,
is
sir.
it possible?
No, sir.
Unlikely.
Yes.
Same thing happens in a submandibular.
Yes, sir.
Even then you should have on and off,
Yes, sir. Fever.
not all the time. So history can be more specific. And you should have a bit of, as said, past history, family history and personal history. Okay.
Actually, there is no thing as a short case. Every case is a patient. There is no shortcut to treat. You have to present it as a short case, but all the relevant things should come in, like personal history. If it is a minor swelling, then also you have to have a small note of all these. Okay.
Okay, sir.
Why the characteristic swelling below in front of your lobule? You should add also, probably in your case in front, behind also, no problem. Why is it relevant?
And the swelling occupies the parotid
Yeah,
region.
parotid region, the parotid gland follows this shape. Okay, I think we'll ask. Go to the next slide. What suppose you said Warthin's tumor? What is Warthin's tumor?
Adenolymphoma, sir. It's
Okay.
a benign neoplasm.
Will it warrant a surgery? Is it a must that you should operate a Warthin's tumor?
Yes, sir.
Is it a must?
If an FNAC proved means we should do the surgery.
No, not necessarily. What is peculiarity about Warthin's tumor?
Benign condition.
It tends to occur bilaterally in
lower
lower
poles of
poles,
parotid.
elderly males, smokers,
Smoking history.
cystic inconsistency. Cystic, it could be transluminant also if it's very clear. So don't have to do all Warthin's need surgery because it's not at all necessary. Okay. You have just mentioned irregular and lobulated.
Yes, sir.
Why should you mention irregular and lobulated? Irregular and lobulated generally don't go together. Lobulation, there is a definite tendency, no problem. Lobulated, why is it relevant for your diagnosis?
So pleomorphic may be sometimes cystic because of necrosis. Sometimes the solid lesion also there. So there must be a lobulation.
Why should you have that lobulation in pleomorphic? It's better to call mixed parotid tumor.
sir,
Pleomorphic adenoma is a
Mixed
histological diagnosis.
Yes.
In your commitment making a diagnosis also, better say mixed parotid tumor. Clinically, then histopathology only should confirm it as pleomorphic adenoma because it has got varied cell lines. It has got epithelial cell, myoepithelial cells.
Pseudocartilage.
So you should have myxoid element, chondroid element, glandular element, cartilage-like structures. That is why you have got a varied appearance. It can produce lobulation.
So what is that term? That is what sir was asking. What is that term that you use for the irregularity in a mixed parotid tumor? Some finger-like things like
Pseudopods. Pseudopods.
Okay.
Okay. So why do you say it is parotid?
So first the swelling occupies the parotid region, and next thing is it's lifted the air lobule.
Why can't it be a lymph node, preauricular lymph node?
So lymph node is first lymph node, and if it is inflammatory, it must be tender, and parotid.
No, all lymph nodes are inflammatory. You can get other lymph node enlargement also without
in
chronic lymph node enlargement.
In a the gland is not much palpable, but the lymph node is movable in case of swelling.
Movable to what extent?
So lymph nodes are much movable. Parotid swelling is not movable above the zygomatic arch.
Yeah,
Curtain signs.
curtain side. Okay. And usually the lymph nodes are beneath the deep fascia and the sternomastoid, isn't it? Usually in that region. Okay.
So in your palpation, can you just mention about the mobility that you got in the swelling?
So it is mobile in a sideways because the upper it cannot mobile in a vertical direction because of zygomatic arch. The deep fascia is attached to the zygomatic, so the mobility is possible in a sideways direction.
So what is the plane of that particular swelling? No mention of that is there.
Plane is deep to deep cervical fascia.
How did you know that?
So asking the patient to open the mouth. If the swelling disappears, it means it is deep to the deep cervical fascia.
How can opening the mouth stretch the deep
Stretch
fascia?
the deep fascia. So the swellings below the deep fascia means the swelling may have reduced the size.
What is the attachment of the investing layer of deep fascia?
In upper it is attached to the zygomatic arch
Oh.
and continues with deep cervical fascias.
Lower attachment is?
Mylar, higher.
Generally, sir is asking question, how will you fix the plane of the swelling? Is it fascia which defines the plane or anything else on which you will say the plane?
Muscle.
Muscle.
Masseter.
Which muscle you will put into contraction here?
Masseter muscles.
Masseter, what is the how will you put the masseter into contraction?
Clench his teeth.
Clench the teeth against? He has to clench.
Yes.
No, generally we put the muscle into contraction by asking to
Resistance.
resistance. In masseter, he has to clench. How will you confirm he is contracting?
What-
Feel the masseter and say the lower pole whether it is contracting. What will happen to parotid?
Parotid is movable in case if in a constricted masseter muscle.
Going repeatedly, you go to the mobility. Okay, suppose if it is fixed to the masseter, what will happen? A swelling which is above the muscle will become more prominent. A swelling which is deeper to the muscle will become
Disappear.
less prominent.
Or less
A swelling which is superficial and infiltrating the muscle also will become relatively less prominent from the original. That is how you generally put the muscle into contraction and test for the size. Okay, did you do that in this patient?
Yes.
What happened to the muscle swelling?
Swelling is not reduced. More
Not-
prominent.
it is becoming
More
more,
prominent.
prominent. Okay. Fascia is very difficult to demonstrate.
Okay.
Okay, so
Why do you want to do a mouth opening test in parotid? What is the concept behind it? Mouth opening test. You don't do it any other neck swellings, isn't it?
Yes. Sir. Parotid may infiltrate in a muscle.
No infiltration. In a normal benign parotid also, sir was asking about the plane. When you do a mouth opening, what happens?
Stretched is
Yeah. Always muscles are contracted, fascias are
stretched.
stretched or made taut, isn't it? When you open the mouth,
fascia is also
the parotid fascia gets stretched so that the parotid gland inside the parotid fascia, enclosed inside the parotid fascia, will not disappear. May not disappear. It will become less prominent. And maybe when you do palpation, the mobility may be bit restricted. So that is peculiar of parotid. That is why you open the mouth and test.
Okay.
Understand?
Okay.
See,
Where will-
no mention of facial nerve was there in the swelling and hold on, okay. Cervical lymph nodes were examined.
Swelling for example.
So what is the diagnosis now?
I just want to ask him. See, suppose you have a node. When will you call a node relevant? Significant lymphadenopathy. You have a node. Not all nodes are significant enlargement. When will you call no generalized lymphadenopathy, or in the locoregional you call it no significant lymphadenopathy, because submandibular node will be palpable for all of us. So you call node significant. When will you call a node significant? In general.
It's located near the region of
In
what?
general, not necessarily here. See, examination, when you because you bring a parotid case, all questions need not be from parotid alone. It is surgery examination, you can be asked. In general, you said node. We are looking for a node. When will you call them significant?
When the node is more than 2 centimeter in
Okay,
size.
fantastic. Not all the time. It depends upon the region.
Yes.
For inguinal region, you can have 2 centimeter. In the region of an axilla, 1 to 1.5. Neck, 1 to 1.5 centimeter. So, not all. Any other criteria?
Consistency of node is
Okay.
hard.
Consistency?
Firm to
The
hard.
size is more, the consistency is more when it is hard and consistency, fixed to the skin or underlying structures, when they are matted. So these are the features, and more than one region, not only one, adjacent regions or contagious regions are involved. That becomes significant locoregional lymphadenopathy. You have to see when you have a node. Simply submandibular node is there, you can't say it is significant. It is palpable, not significant. Yes.
How did you come to this conclusion that it is a pleomorphic adenoma? You
So
can
first-
pick out points from your history, you can pick out points from your examination.
First, from history, it is more than fifth decade of age, and a woman, which is pleomorphic adenoma, is more common in women, and it's a painless swelling, not associated with the fever, and lifted the ear lobule. On examination, firm in consistency, lobulated mass, and on palpation, the retromandibular groove is obliterated in inspection, and on palpation, the swelling is not fixed, so it is benign, and lymph nodes are not palpable, no facial nerve involvement, so that will be benign tumor, probably of maxillary tumor.
Can it be a Wathen's tumor?
So Wathen's tumor are mostly occurs in a case of smoking history and in a male, more common in male, and it may be of bilateral in origin, and it occupies the lower pole of the gland. So all features contradict.
Can you expect any difference in consistency between a pleomorphic adenoma and a Wathen's tumor?
Wathen's tumor is smooth and cystic in consistency, but pleomorphic is.
Can it be a carcinoma?
No, sir, because facial is not involved, and there is no rapid growth, and no blood vessels or dilated veins over the swelling.
Can this be a matted intraparotid lymph node enlargement?
No, sir, lymph nodes not palpable.
Intraparotid lymph node enlargement. Can this swelling be a matted? What is the surface of the swelling?
Sir,
What is the surface of this swelling?
lobulated surface.
Lobulated surface. Can it be a matted lymph node lymphadenopathy within the parotid fascia?
Mm.
How can you differentiate this from that?
So in parotid, the lymph nodes are embedded in the gland. So the lymph nodes are preauricular only, superficial.
It's not superficial, it is lying within the parotid.
Yes, sir, so that
Which one will you go for? Will you go for a pleomorphic adenoma or a lymphadenopathy?
pleomorphic adenoma.
Why?
First is most common one.
Exactly. Common things are common. Except one thing. What is it? One common thing is not that common. Common sense, my dear.
I add one thing, sir, extension of what he said. When if students comes to us, I'll say, what is medicine? It is 90% common sense and 10% David sense. So I said this, but because the textbook of medicine belongs to, so if your common sense is 90% of the time will make a correct diagnosis and pass. So you prevail, common sense prevails. That's what he has said, common sense. So you said, suppose if this patient has got a facial nerve palsy, is it possible for it still to have a pleomorphic adenoma?
No, sir,
You do FNAC, that states pleomorphic adenoma like picture.
maybe an perineural infiltrations by
What is that stage which has happened in that pleomorphic adenoma? It has become malignant.
Malignant. It's
Well,
transformed into
carcinoma X. Sir has asked you one question. If it happens to be a malignancy, which malignancy is more common?
expleomorphic.
Okay, not pleomorphic. Otherwise, purely you are going around pleomorphic alone. We will come out of that and
Mucoepidermoid
carcinoma. Mucoepidermoid carcinoma. Okay. In which malignancy of parotid you examine for lymph nodes? Lymph node enlargement is common. You have adenoid cystic carcinoma, adenocarcinoma, epidermoid carcinoma, carcinoma ex pleomorphic adenoma. In which malignancy? I have not told only one. That is the answer. In which malignancy lymph node enlargement is common?
adenoid cystic
Which
Acina, sir.
histologically which cell will go to node?
epithelial.
Adenocarcinoma or
Adenocarcinoma.
squamous cell carcinoma?
Squamous cell carcinoma.
Then I will mix and tell you. Mucoepidermoid carcinomas in salivary glands. They are the one which produces lymph node secondaries, not adenoid cystic. Rare, adenoid cystic is rare. Okay, what do you want to do for this patient?
First, I will do investigations to confirm.
55-year-old woman, 5 months duration, slowly progressing, lobulated mass, variegated consistency, mobile, no features of clinical features of malignancy. You suspect it to be a benign. Can you call pleomorphic adenoma purely benign? Absolutely benign. Desmoid tumor, pleomorphic adenoma are not. Why? Madam is giving you prompts. They invade through the capsule, sending pseudopod like structures. That is why we are doing. We are not doing for a benign tumor. What will you do for a surgery for a lipoma?
Simple excision.
Simple. Oh, nothing is simple, man. Excision. Why you want? You can't collect simple money. You have to collect money after doing surgery. Excision. If you say simple excision, patient will not pay you. So say excision biopsy. Okay. But for a pleomorphic adenoma, you are doing a superficial parotidectomy or wide local excision. Why? You had an answer for that actually. It sends pseudopod like structures.
So perineural invasion is.
Hey, you are sticking onto some points which you want us to pull. Why perineural invasion happens? What are the types of perineural invasion in malignancy? I am listening also. I am asking you, what are the types of perineural invasion? When you call a nerve is infiltrated. You want answer, man.
First you say what is perineurium. You only invited all these questions.
There are some good batsmen who play according to the strength and score good scores. You should play according to your strength. See, perineural invasion, more than 1/3 of the circumference of the nerve is involved, or there is a structure of the nerve has got a malignancy. Don't get into that. That is histological diagnosis or MRI diagnosis. Tell me, how will you proceed in this case?
Investigations to confirm.
Fantastic, man. You have mugged up my slides. Yes. You know that I am going to be the presenter next to my examiner. What do you want to do for him?
So investigations like fine needle aspiration.
I'll kill you.
Ultrasound. Ultrasound. High frequency ultrasound.
You have got a tumor. Will you allow a pathologist to put a needle or do ultrasound, man? Why, man? You do differently for a patient. You do always non-invasive investigations first, then invasive. Why?
Ultrasound.
Ultrasound. Okay, right. Somebody said like that. See, it invades, produces hematoma, alters the architecture. Is it because of tumor necrosis and bleed, or is it because of your FNAC you have a bleed? We don't know. Yes. They have rang bell. Tell us, you want to do ultrasound next?
Next up, FNAC.
FNAC.
Next is CT scan or MRI.
When will you do?
When large tumor suspected.
Yes, large tumor, deep lobe tumor, malignancy. Yes. Right, FNAC says pleomorphic adenoma. What will you do? Why it is called pleomorphic adenoma?
Different type of cells.
Okay.
Like epithelial, myoepithelial cells.
Okay.
Presence. Morphology is different.
Can anybody tell me what will be the cut section of morphology of a pleomorphic adenoma?
White.
It has got a word. Yeah, who said that? Yes, man, fantastic. Give him a big hand. Variegated appearance. Variegated appearance. Yes. Cut section. Then, what do you want to do?
Treatment.
Treatment, yes. Okay. What treatment you want to? FNAC has confirmed. What treatment you want to do?
Superficial conservative parotidectomy.
Okay.
Superficial conservative parotidectomy. Is there a surgery like that?
Superficial parotidectomy.
Superficial parotidectomy means it is conservative. If you do total, you can do radical, total parotidectomy or total conservative. Superficial parotidectomy means it is conservative. You are conserving the nerve. So that is the minimum surgery you should do in a pleomorphic adenoma, isn't it?
Yes, sir.
So there is one school of thought. After pleomorphic adenoma, can you leave the patient and sit quiet, or?
No, so complications are there.
We will deal with the complications later on. Your treatment part.
Drains should be placed.
That we always place. No, the surgery is over. The biopsy has come as pleomorphic adenoma.
Follow for recurrence.
You can follow the patient for recurrence. What causes recurrence? Do you expect recurrence in pleomorphic adenoma?
Yes, sir. Pseudopods.
There is a serious chance of recurrence in all pleomorphic adenoma. What can you do for preventing the recurrence?
Post-op radiotherapy.
Oh, good.
Post-op radiotherapy.
Okay.
Yes, that is it. Yeah.
Yeah. When will you give radiation? When will you give radiation? It is too much for you for undergraduate. When
Yeah,
will
yeah.
you give radiation in a pleomorphic adenoma? They are not answering, madam. That's why. When generally we will combine both UG and PG and kill both, you are not allowing us to kill your postgraduates. Yes. Whenever you on the table, the capsule is breached, there is spillage of tumor. When a pathologist says that there is breach of a capsule and extravasation, there is gross on the table or gross by the pathologist say that it is no margins are not free of tumor. You should give a post-operative radiotherapy to prevent recurrence. Okay. How will you identify the facial now?
Sir, tragal point.
He is a very smart fellow. He was taking notes all the time and he was saying, I insisted certain points twice, thrice. This fellow has taken it up. Okay. Suppose, what is that point called as?
Conley's point.
Ah, you are said man. I didn't say Conley's point. I accepted that you have said. It is called Conley's point. Okay. Suppose you have failed to identify there. What is the other way you can do? I'll ask you a next level question. To prevent PGs irukangala madam. To prevent auriculotemporal syndrome or Fry's syndrome, one surgical technique will prevent you from developing a auriculotemporal syndrome.
Extracapsular dish.
No, leave it, man. This is to postgraduates. What way you will prevent what is SMAS? Superficial musculo-aponeurotic system. You are defending your postgraduates, man. Yes, superficial musculo-aponeurotic layer of the face. If you take that, the skin is prevented. Why auriculotemporal syndrome happens?
So because there is a connection between parasympathetic and sympathetic fibers. When you leave open as such and removing the superficial lobe.
Which is parasympathetic, which is sympathetic?
Parasympathetic is auriculotemporal nerve, which get connected with the greater auricular nerve, sympathetic innervation.
Okay.
Causes stimulation of the glands over the skin.
Okay, Superman. He has read nicely. Give a big hand. Only one thing you must remember. Parotid is supplied by parasympathetic, which runs via the inferior salivatory nucleus, goes to the aortic ganglion. That is parasympathetic. Your sympathetic is to which organ? Skin. Skin is the one organ in the body which is supplied by parasympathetic. Rest of the all the glands in the body are innervated by parasympathetic. Skin is by sympathetic. Rest are all by parasympathetic. That is why whenever you eat, skin gets stimulated. Worst nightmare for a surgeon and a patient. So that can be prevented by doing SMAS, musculo-aponeurotic, superficial musculo-aponeurotic layer. Okay, suppose nerve cut panta. Want to be a surgeon or what?
Yes, sir.
Then you cut panta. You take it that way. What will you do?
You can give switch ring.
Oh. பக்கத்துல இருக்கிறத விட்டுட்டு எதை ஸ்விட்ச் பண்ண விட? Which are the nerves in the body that can be used for grafting?
Greater auricular nerve.
பக்கத்திலேயே இருக்கிற nerve.
Greater auricular nerve.
Greater auricular nerve. That is why you should preserve the greater auricular nerve in parotid. It's not sacrifice. You should keep them. You can have all the plastic surgeons do nerve grafting. Okay. Yes, sir.
Again to PG postgraduates. Sir has given you one tip to prevent Fry's syndrome, isn't it? To keep the flap thicker. Previously we used to take very thin. We used to invert and see the hair follicles in the flap. So we got, it's very difficult to prevent Fry's syndrome in such case. So now we are keeping the flap more thick. Are there any other methods to prevent Fry's syndrome? You can do or take some steps to prevent the nerves from the parotid region to reach the skin region.
Grafting.
Not to you.
They have produced one fellow with a very nice preparation and rest of them are keeping quiet. All of them answer.
So you can keep some barriers inside.
Yes.
So you can keep some sternocleidomastoid muscle part, you can reflect to that part and keep it in between. 1. 2, you can use some membranes like or fascia like temporalis fascia, etc. inside. So that will prevent the unwanted communication that will develop when the nerves are regenerating. Understood?
Second thing, Sarah has also tell you the treatment for phrase. Suppose if it was developed phrase, you have to dissect that nerve and put a interposition. And second thing, what I will do, I will not keep a very good suction drain post-operatively in parotid. This is my way. If you keep a suction drain, it will suck out all the secretion, make the skin becomes adherent to the parotid. If you give a corrugated drain, it will drain partially, it won't drain also. So there is a layer of seroma which forms naturally. It will also produce a cosmetically good defect. If you keep a suction, it will suck out everything, produce a defect. Skin will get stuck straight away and also produces chances for auricular temporis. This is not given in any books. We just follow. Our teachers have kept only corrugated drain. Why those people have kept, we don't know. We also started following corrugated. Corrugated that's one thing which prevents. Okay. Okay, I think we'll give a big hand because already bell has rang long time back.